stronger than the tears in your eyes.
Hello, everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at BrightMD. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Stay on after the webinar and learn how to make homemade pasta with Master Chef Matt Migliori. And with that, I will throw it over to our moderator who joins us from MedCity News, Orundoti Parmar.
Thank you very much. Hello, everyone, and thank you for joining us today. We have a very interesting panel with experts who touch different parts of the patient's journey and thereby affect the patient experience. So I'm very confident that we'll have a very engaging and meaningful discussion today. But before I introduce them, I seek your indulgence for 15 seconds to share a personal opinion. As a journalist and as a citizen of this republic, I have to acknowledge the events of the past 24 hours in our nation's capital. I sincerely hope that all of you within your own organizations have leaders that have a greater fidelity to the truth than we have managed to elect in our executive and legislative branches. So with that, I wanted to introduce our panel. First, we have Adrian Boise, Chief Experience Officer at the Cleveland Clinic. Then we have Nirain Gandra, Chief Commercial Officer at Cedar. And then we have Ray Costantini, CEO and co-founder of BrightMD. So welcome to you all. I wanted to start with very brief introductions where you talk about yourself, your role, and a little bit about your organizations. So why don't we start with Adrian, and then we'll go to Nirain, and then we'll go to Ray. Go ahead, Adrian.
Hi, everybody. I am a normal person, but a neurologist and the Chief Experience Officer at the Cleveland Clinic. And my role, I run a fabulous team in collaboration with my quality, safety, and CI colleagues. That's made up of spiritual care and ombudsman services, clinician communication, training, resources, complaint management, all sorts of fun stuff. So our primary role is to think about the reduction of suffering and hopefully creation of some joy for really person-centered care. And that's what gets me going every day. Thank you.
Awesome, Adrian. So I'm Nirain Gandra, I'm Chief Commercial Officer at Cedar. Really excited to be on this panel. I'm also a physician by training. I'm an internal medicine doc, but a few years ago, I branched out to more kind of like the system level business side of healthcare. And that's how I ended up getting involved with Cedar right as the company was getting started. And really our whole vision is to make the financial experience and the administrative experience part of your visit really seamless and simple for patients so that becomes a non-issue and people can focus on the clinical care. So that's the mission of our company. And so excited to be part of this panel and discuss with Ray and Adrian, how they're looking at the digital experience as well.
And a pleasure to be on the panel. It's a great group of folks. Also, internal medicine trained physician by background, spent a lot of time working on digital health on the healthcare delivery system side of things at some large West Coast healthcare delivery systems before starting BrightMD. And BrightMD is a company that really is focused on helping to bring care automation to the delivery process, making it so that clinicians are not having to be burdened with so much of their time spent so far below top of licensed practice around administrative burden and documentation and really information gathering. We want to be building digital tools that help make care more consistent, more accessible, more affordable, and more delightful for patients and for providers by removing that burden and giving that time back. So.
Great, welcome to you all. So Nirain, I wanted to start with you, and the primary reason for that is you talked about the patient financial experience. And we have heard so much about the word empathy, and I think of empathy, I think of a physician's bedside manner and things like that. But now, given the pandemic and so many people unemployed, the financial experience that a patient has is probably more important than ever before. So I'm wondering if you could talk a little bit about how you help your hospital customers deal with this patient financial experience at this point in time.
Yeah, great question. So essentially, like when we kind of look at the problem, right? And you have a whole bunch of people who are looking to get care, but one of the questions that I think comes up in the back of people's minds when they're thinking about getting care in the United States is, hey, can I afford it? Will my insurance cover it? I think those questions are actually really hard to get the answer to before you go in and do something. So there's a whole lot of patients who kind of don't get care for what they need because they have this question. And then there's another group of patients that I think goes in, gets the care, and they're surprised by something that happens or something unexpected happens. Or even if they get a bill after, it's not easy to pay off. Like I personally had an experience with, a place where my wife is a physician, and I got a bill that was so complicated to resolve, and I was actually trying to pay it, right? And we had the health system's own insurance. And so we were trying to pay, we were trying to resolve it, and it was still very difficult to act. It was still a negative experience. So I think this has been exacerbated by COVID, obviously, right? So you have a whole lot of people who now are underinsured more so than before, who don't have the coverage that they used to have, or who can't pay out of pocket. So really what we've tried to do is work with our health system partners and say, what can we do to make this experience smoother? So that means making things simpler, making things easier to understand, easier to view, and also different kinds of payment options, right? So one of the things here is making sure that insurance is collected and people aren't getting bills for things that should have been covered anyways. And the other is stretching out payment plans or offering discounts to relieve the financial burden. I think we've been really excited to see that a lot of our health system partners are thinking about this the same way, that the patient experience has to be on point, because I don't think anyone wants, folks to delay care or not come back for care because they had a negative experience with this type of thing here. And from our perspective, our technology is essentially geared towards simpler engagement. So using things like mobile engagement, emails, et cetera, making things like 1-2 clicks very simple to understand, and explaining things in words that patients are going to get, not in kind of technical jargon of like CPT codes and DRG codes and all of that, which is always a complaint from patients that a lot of the communications don't make sense. So we're really trying to simplify and give people more options and make it all accessible online without having to call somebody.
That makes sense. So Adrian, I'll go to you. Obviously, Niren addressed the patient financial experience piece of it. From a hospital perspective, what are some of the challenges you see in patient communications in trying to give them what Ray described as a delightful experience?
You gave me a real softball there, didn't you? Well, just to piggyback off of the conversation you were just having, I mean, first of all, the whole nation and perhaps the globe needs to understand that the billing experience is part of the patient experience. It's not asked about on a single patient satisfaction survey, but it should be because it's one of the biggest pain points for patients. And so, and the ease of that process is actually a measure we've introduced so that we can begin to understand how easy is it for you to do anything you want within our system. And if it's complicated, we should be spending an awful lot of time there. So I want to celebrate the work that you just heard about. So important. We did a lot of design thinking around billing and learned there are all sorts of patients that don't pay their bill for a variety of reasons. And we need to have maybe predictive modeling about your ability to pay and real-time insurance verification. All these things we think would be sort of the norm in any other industry. Half patients still don't know what their cost of their services is, and a whole lot more are searching for whether or not their insurance covers it. So it's a huge issue. I don't know that we've cracked the code on communication, but I would encourage all of us to kind of step back. Empathy you kicked us off with this great concept of empathy. Empathy is usually thought of in that space of, oh, it's just your clinician and the patient, and we're having this intimate, fragile conversation. And yet I really challenge all of us to think about what I love to call empathy operationalized, right? If you could imagine what it's like to try to bring your 87-year-old mother to an appointment during COVID, and she can't hear and she wears dentures and she doesn't have her glasses that day, going through the screening process, coming up to the front desk because she's worried about a breast mass, we wouldn't burden them, right? We wouldn't create unnecessary suffering at the desk about registration and your copay and you didn't pay your last bill. We would just make it easy. And so empathy in these contexts is incredibly important. We have tried to craft our communication very carefully. If you're having a virtual visit, what does empathy sound like in those settings? When we're communicating how we're supplying vaccines, what does that need to sound like to our populations? And empathy is at the core. So I would just say, we've spent a lot of time this past year during COVID. How are we going to have conversations when people don't want to wear a mask? You know, all of that has to get wrapped in curiosity about the audience we're trying to understand, which of course is our patients and our people, and work on those messages. So our empathy trainers have spent a lot of time this year with our marketing team and communications team to marry up the messages more personalized, more targeted, more deliberate for those that we're really trying to reach and impact behavior change around. So that's a pretty global answer, but I hope it gets at some of what you're asking.
No, that makes sense. And then to go to you, Ray, your company has created sort of a patient experience checklist for your customers. So how do you weave empathy through a checklist? Can you expand upon what the checklist comprises of?
Oh, goodness. Well, I mean, I think we use the checklist as a tool to be able to help health systems think about what kinds of things are important to the patient experience. What we've created in a broader context is really, I think, very aligned with what Niren and Adrian are both talking about. I mean, you know, some of the biggest challenges that we see around patient experience are that by the nature of the industry that we've created, I think we've taken a lot of the humanity out of the healthcare delivery system process. And the interesting thing is that that's both for patient and for provider. When you think about what clinicians have, you know, if you put on a product hat or a business hat along with your clinical hat, what do primary care providers have to sell to their patients? They're selling 20-minute increments of their time. And if a patient comes in with a cold, we're able to sell them 20 minutes of our time. And if they come in with diabetes, congestive heart failure, COPD, a foot ulcer, and a raft of social determinants issues, we have to sell them 20 minutes of our time. And I think that has taken that, combined particularly with the burden of what we've asked our clinicians to do in each of those visits, they're spending most of their time on the keyboard, not in interaction with the patient. And so bringing tools that can liberate those providers, give them the opportunity to be able to give them just a few minutes of time for the patients who really want to just feel better faster and they want that care for their cold. And then that also liberates all of that time so that they're actually able to put in more time, more humanity, more of their own personal joy back into the interactions that they have with those complex patients. It's really about understanding those patient needs, understanding how this incredibly important interaction between clinician and patient plays into that, and then giving both clinician and patient tools that can make those better interactions possible. It also, coming back full circle to what you're talking about, it means making that care more accessible. And accessibility is convenience. It means making it available in their home or in their workplace or on the bus, on the way to work. I mean, we all have different places where we need to be able to access that care. It means making it more affordable. And part of the reason why healthcare has become so unaffordable is because of this supply-demand issue that our industry struggles with. We've got almost a 20% shortfall of clinician capacity relative to the patient demand. And given the backlog of clinical care that's built up behind the dam during COVID, undoubtedly that's going to be worse as that we're able to start releasing that more and more. And then we're likely to be exacerbating it even more because physician burnout, which was already at 50% of primary care providers were experiencing moderate or worse burnout prior to COVID, the likelihood of that being substantially increased. I don't think anybody is under the delusion that that's not going to be the case. We're going to see more clinician attrition. We're going to be losing that capacity, giving those docs the tools that they need to lift that burden, to let them bring humanity back into the care delivery process. I think that's those are the kinds of things that, if health systems aren't thinking about that, the changing competitive landscape that they're operating in, I think, and the changing expectations of healthcare consumers and patients, I worry that organizations, these new entrant competitors, could really leave more traditional healthcare delivery systems in a position where they're nowhere near as relevant as they deserve to be, given the quality of care and the commitment that they have to care breadth. So
that's interesting. I think I live in Silicon Valley, and so obviously the general philosophy here is technology to ease burden, but I'll get to Adrian in a second and talk to you about how you can have empathy through these tech tools. Can you do that? But before I do that, I wanted to mention to our audience that the Q&A channel is open, so feel free to ask any questions to any of the panelists, and then I'll try to sort through and feed them through our discussion. So Adrian, back to that question. You know, when we did our reporting during the pandemic and continue to do so, one of the things that came, you know, back from every hospital system that we talked to, even smaller systems, is that they found the chatbot and the Microsoft chatbot to be amazing. So I'm wondering whether that is true, and what other tools have you found useful at this time, and how many of those will carry over once we hope this thing dies down?
Yeah.
Three questions at you.
That's okay. It's good, right? So, I mean, if we've walked the patient journey, that might be a helpful way to look at it, right? When patients originally come to the site, if they're greeted by a chatbot that can direct and answer some of their most basic questions, and it's useful and relevant and timely, that's been very effective to alleviate the burden from people on the phone as a first landing and a first touch. The second phase is getting an appointment. You know, if people can't get an appointment, they're never going to experience your service, you know, your fabulous, high quality services. And so making sure we're leveraging online scheduling when we can, right, has been an effective mechanism. Streamlining that home registration as opposed to in-person registration has also helped with safety and access. In our surveys, people are really willing to seek and continue to seek primary care, mental health services, and dentistry, interestingly enough. And some of the specialty care, they may delay a little bit more. So big demand for those services. Other features of communication that we've tried, digital engagement around if you have tested positive, for example, is something we launched with our EHR. So developed an entire path or journey that helped throughout your COVID positive status connected to workflows and primary care. And then tried to do some creative things within those tools to make them feel like an actual human caring partner, right? Check in on your stress level, tips to talk to your family, tips to keep your family safe. Have you ever thought about advanced directives, which is another piece of the patient journey we never talk about, is you're honoring your end of life wishes, even though that's a core component of patient-centered care, and incorporating that. And as well, giving an opportunity, a little bit of optimism, you know, giving patients the opportunity within those tools to give kudos. So we had a big kudo board where patients could make silly videos of themselves or draw pictures and post it to our caregivers. And then our caregivers, when they enter the clinic, walk by those every day when they're coming in, just to try to create some lift, to say, keep going. We have whole communities you can't see behind you. So creativity, you know, I mean, I'm very left brain with my neurology side, but my ballerina side, I think, brings out some of that. We need to be engaging both parts of the brain to make these communication tools work. Bringing the technology solutions alone, I think we've learned, without really understanding what people need, is not helpful. So for example, if your communication tool is launched through a patient portal and only half your patients use the patient portal, I'm sure it's amazing, but nobody's, right? So how do we solve for those types of practical problems? We need to just fail and iterate and keep learning. That's part of our commitment, I think, to being a highly reliable organization, as I learned from my quality and safety colleagues. Important to say to you that we've also worked hard to make sure that empathy is part of all those designs. And you're going to get sick of me saying that, but that's okay. Never before have I seen more of a need to make sure we're baking humanity in. So when we're connecting over virtual visit, we heard from both patients and clinicians, it's not possibly going to be the same as in person. And I mean, I can tell you, I care for MS patients, and it's not empathic to have them in the middle of December schedule 2 hours to drive to the Cleveland Clinic, park in the icy parking lot, walk across in their walker, wait for me for half hour in the waiting room. That is the least empathic thing I could be doing for my patients now. So literally connecting where they are, there's no greater example of empathy. We've worked hard to create digital playbooks as to how you can embed empathy in those virtual conversations. We just published that website Manner paper, which might be worth taking a look at after interviews with clinicians and patients as to what were the best practices in those settings, leaning in, commenting on this cool picture that Ray has behind him, or the blanket that he has, or asking him about the people who are in that photograph, and Niren asking him what's going on with the blank space. Like, is that soothing to him? These are ways that actually enrich the meaning for me as a clinician, right? Ray nicely talked about connection. We need to understand that part of the antidote for burnout is meaning. That's been nicely proven in studies. So when we can create that meaning for clinicians, which really is in those personal connection moments, boy, have we hit it out of the park. And clinicians need that now more than ever, and so do patients. I will comment that for my MS patients, sometimes it's the rug they trip over, show me your refrigerator. For the last patient, it was a big bottle of Crown Royal sitting behind them, and we had a conversation about how that fits into your coping. We need those moments of levity and real that remind us all we are humans that crave that kind of connection. And as a neurologist, I can tell you that's neurologically true.
So Niren, we'll continue on that theme of empathy. I'm wondering whether the goal of empathy can be forwarded by having transparency. And, when we chatted before the conference, you talked about how that has increasingly become important to the patient experience and the patient journey. And we are on a certain trajectory towards greater transparency. So within your own organization, how do you address that?
Yeah, I think one of the things that, and Adrian kind of alluded to this, when you think of the patients as people, right? Like, for folks like us who've been doctors for many years and then work in healthcare, this becomes our job. But for a patient, this is a relatively tough period of their times, right? Where you get a lot of healthcare. That's not exactly fun, right? So we want to make this as simple for them as possible. And if you think about, you go to a hotel, how much you're going to pay for that hotel. You check in, then you check out, and everything is done. But in healthcare, we've kind of have this huge black box that takes place, that is this financial component. So is your insurance going to cover it or not? If your insurance covers it, how much is it going to cover it? Actually, what are you even going to get when you go in? Like, all of those questions are in the air. And when you think about an episode, your bill, I think if you ask the average patient, before they go in for an orthopedic surgery, what do you think you're going to owe? You're going to get answers anywhere from $500 to $5,000, and all of them might be right in certain situations, right? And so I think what we're kind of looking at this and saying that pre-visit experience is where we really think technology can radically change that experience. So after the visit, it's super complicated. There's a whole bunch of systems that you have to integrate and all of that. We think we're getting to making that experience better. Before the visit, I think the real key is, can you provide people an estimate of what is going to happen in terms of what insurance is going to cover, How much are you going to owe? And can you let people act on that before they even go in? So could you set up a payment plan beforehand? Could you fill out a financial aid form before you actually go in? And the way we are looking at it is in the next 5 to 10 years, that's our North Star, that every time you go into a visit, especially a planned one, that you're going to know exactly what you're getting yourself into. And then throughout the journey, that becomes a reference point of how this is being communicated with you. Generally, like the way the black box is today, I think is, if you look at 25, 50 years from now, that's unsustainable. So we think that's going to change. So that's where we're seeing a big opportunity. And when people say transparency, I think one of the things that I would caveat is people see the transparency law that was created, right? Where you put up different costs for different procedures. It's a good step, but it's definitely not the final step because it's not actually individualized to the patient. It's basically like kind of a shopping list of items, yeah. But when you're a specific patient, your situation is much more complex than that. So we see big opportunities to personalize that transparency experience. And I think that will actually improve people's relationships with their providers, with their, like how they interact with doctors, and will make people engage with clinical care more because we are making this particular part of it easier.
Makes sense. So Ray, a ton of questions have shown up in the chat. So I'm going to take one of those and send it your direction, and then we'll try to go through the panel and answering the same question. What about the future of care outside the hospital system setting? Where does at-home care fit into this equation of improving patient experience?
I think this actually fits in a lot of ways into the same theme that was already being talked about. It's a great question to bring into that mix. In a lot of ways, I mean, if you think about the definition of empathy, it really is. It's being able to understand a situation from the perspective of another person. I think healthcare historically has had a pretty long and pretty well-established track record of telling patients what they're supposed to do rather than meeting them where they're at. And I think that that's something that's starting to change, which makes me as a clinician and as a patient happy. I think that's a change that healthcare needs to be embraced. If traditional health systems don't, there are certainly new entrant competitors who will. But it's understanding that those needs change, and they change based on patient preference. They also change based on the clinical circumstances. And this is one of the complexities of healthcare, is that those things are sometimes in conflict with each other. We want to understand patient preferences, but what the patient wants may not be an available option because the care necessities make that not a possibility. I think we should be working to enable that whenever possible. But I think in some ways, the question that was being asked about care in the home, I think it's absolutely a part of that. Understanding what those patients' needs are, and then being able to address them in the most convenient way possible, the way that patients prefer, is definitely part of that. In some ways, I think it's interesting that with the expansion of remote care and telehealth, I think there's some interesting questions that come up around that. And I think the newness of its prevalence makes those questions even more interesting and relevant. One of them is, what's the problem that's being solved there? And I think really it is a problem of geography as a barrier to care. And it's one we should be trying to address. To Adrian's point, when we can deliver care for patients appropriately and safely in a more convenient way, we should be doing that. But even more so, I think this idea of thinking about those two different venues of care, care at a distance, care in person, as being in competition with each other, I really think that it's a pretty anachronistic way of thinking about things. It's not about telehealth versus in-person care. It's about how do we use digital tools to make that experience of care delivery seamless, accessible, appropriate, high quality across those venues. In fact, the best experiences of care are arguably ones that seamlessly bridge between those. One of my favorite examples around this is, if you envision the ideal experience of care for a patient who's got something like a broken toe, you're never going to be able to take care of that. Without getting into Star Trek realm, which I don't think we're ready to do today. You're not going to do that in the home. That requires imaging. It requires a laying on of hands, and that involves an in-person setting. But what you don't want is to have that patient have to sit in the waiting room of an urgent care clinic for an hour before getting roomed, and then sit in the room for 2 hours waiting for the imaging. The ideal experience around something like that is really one where the patient is answering those questions and giving the clinician information while they're setting up their appointment. You're tying together that front office experience that Niren's talking about with the clinical experience. You're getting them registered, you're getting them set up with their appointment, you're gathering their billing and insurance information, and you're handing the appropriate relevant clinical information to the provider so that when the patient shows up at the urgent care clinic, they have the order waiting for them and they get roomed straight into imaging. And you turn a 3 to 4 hour urgent care experience into a 30-minute experience because you've got the chart note written, you've got the orders placed, the patient experience is delightful, the health system is better off because the clinical experience makes them a more appealing and sticky experience for those patients. You think about all of those things, it's incredibly powerful. Adrian, I'm guessing that you that was either adamant agreement or a differing opinion. I'm very interested. Tell me where you're thinking about that.
Well, you made me think of something we also don't really talk about, which is avoidable suffering created by waiting. We wait for
gosh,
right? We wait for the appointment up to 29 days on average. And then we wait for, once we get there, when we studied that here, it was 6 to 93 minutes that patients wait once they arrive. And then we send you back to the room and you're waiting. And that's even worse because now you're in a gown in a room and it's cold and your feet are freezing. And
so much of it is built around the physician workflow, and we can make it better by improving those things.
That's right.
Yes.
And 36% of patients on the inpatient side complain about the delays. So think about all the solutions we're talking about, cool things in home registration and cool things on the billing that absolutely need to get done. And I'll submit to you too, if we don't solve the waiting problem for patients, because what happens while they wait, right? The brain has a mechanism called sense making. So the brain starts filling in all those gaps, right? Oh, Ray must not care about me because this happened last time too. This place never seems to really improve how long I'm sitting here. I wonder if they even pay attention. Have they forgotten about me? I'm never coming back to Cedar, or, right? So the brain rapidly moves up that tree and makes an assumption about your service, and then you've lost that patient. And that patient, 7 times more the expense to get them back than to keep them. And so this is an incredibly important conversation, because although many of our tools are trying to solve really important problems, chronic health care, remote monitoring, billing, I also want to call out that there are some fundamental problems that really irritate people that we have not cracked yet, and nor do we spend a lot of time talking about. It's not sexy to talk about the waiting time. But boy, if we don't solve that problem, people are going to continue to be pretty irritated with us.
Adrian, I got to reinforce that just a little bit. I think some of the things that we've seen with the BrightMD platform that make patients the happiest, one of them is they're able to get care generally with a wait time of just 6 to 7 minutes until they actually have their prescription on their way to the pharmacy with the diagnosis that they're reviewing. That's a huge piece of that patient satisfaction. The other one, though, coming back full circle to something we were talking about earlier around that empathy, is that sense of being heard. And this is one of these fascinating things to me. We often get questions about, I didn't really talk about how our platform works, but if you think about it as kind of a virtual medical resident that interviews the patient, reviews the EHR system, gathers all of that information, and then turns it into a chart-ready documentation for the clinician. One of the things that's really fascinating, the feedback that we get from patients, what makes them really happy is in fact the thoroughness of the interview. We get feedback on a regular basis in our usability testing and even from our real life patients. I've had this condition 3, 4, 5 times in the past, and my doctor has never asked me these questions. Why not? And it's not that clinicians don't care, it's that we put them in this impossible position of having to see 20 plus patients a day, and they don't have the capacity to be able to do that. It is that empathy. It is making the patient experience better.
I was going to pull Adrian's leg a little bit, Niren. Did you see how she said that I don't want to come back to Cedar and not I don't want to come back to Cedar?
I did. I was going to be nicer.
I meant some other large hospital system.
You meant, sometimes when people see my name tag, they think it's Cedar-Sinai. So you meant Cedar-Sinai.
No, I didn't. I mean, it's just like, I just came up with that.
I'm having way too much fun here. We're going to stick with Niren. There's a question for you, Niren. How are you and Cedar thinking about making the transparency experience better for patients? Where do you see the biggest gap to make this successful versus just another transparency mandate?
Yeah, I'll get into that in a second. One thing I will just add to what Adrian and Ray were just talking about is this waiting experience. One of the things not to forget is waiting on the phone. So
Yes.
if you call in and you're waiting on the phone, I think that's a frustrating experience. And actually, when we think about our pre-visit product and our pre-visit experience, that's really a lot of what we've geared it towards of, can you do a lot of this stuff self-service? Can we actually feed you the information to do this with clicks? So you don't have to call in and spend a lot of time on hold, or do it when you get to the visit and you're filling out a clipboard in the waiting room. By the time you come to the visit, are you basically done with it? And then, or done with the pre-visit kind of checklist that you have. In terms of specific,
could I expand on that just half a second more?
Go ahead.
Because one thing that we've seen that's even worse than, because I agree, waiting in a waiting room is bad. Waiting on the phone is worse. The thing that we've seen be even worse than that is waiting on a video call, which is really in some ways a fancy phone.
Yes.
I just wanted to insert that we've seen exactly that same kind of progression of dissatisfaction and frustration coming from all those things. Sorry, I just wanted to mention that. Go ahead.
Totally agreed there. But in terms of like the specific question about transparency, I think the thing that's made transparency really hard for health systems is that there's a very complex process that's adjudicating the claim, right? So you're going in and there's a few elements of uncertainty. One is if you book an appointment because you want a routine checkup, but you go in and you end up having chest pain in there, that appointment actually changed, right? You went from going from a preventive visit to having a E&M level 5. And now the amount that's been billed has changed. So the insurer is going to get a completely different claim than maybe what you were anticipating before the visit. Now the insurer, how they adjudicate or don't adjudicate, I don't think providers have had very good insight into that, over the last like 20, 25 years. There's some tools that have come out recently that are improving that. Then the next question is, after all that happens, how much deductible is left on the patient's account? How much, what is this patient's like insurance structure? Do they have the same insurance? Like, is it all of those questions need to be kind of answered for you to come back with an accurate estimate. So I think one of the things that we think is going to really happen over the next couple of years, and we're building some technology on our side to do this as well, is basically trying to track like all of the bills that we're communicating on and say, what do these situations usually lead to? Can we actually provide a better estimate up front? And then when you provide that estimate, can you actually explain it better to patients? So even when you actually get a bill, can you explain it in a way that people understand it? So I think some of it is kind of more on our design and communication pieces that we're working on. And some of it is how these systems interplay with one another. And can you actually create a better estimate? I do think parts of it I would view as like, hey, we're working on it. We do think we will figure something out in the next few months to years where we think we can radically improve the accuracy of estimates and like essentially personalize when we show that to a patient as they're getting into their care journey.
Adrian, there are a couple of questions from the audience on where they might be able to read that white paper you mentioned on virtual empathy. If you can mention it, and if you have it handy, if you can put it in the Q&A, that would be great as well.
Sure, I think I did. So I copied the link here. If not afterward, I'll share it with the team and make sure that it's accessible for people if that's helpful, but I'll try to post it again. It just got published in the Journal of Patient Experience. One of the primary authors is Amy Windover, if people want to try to take a peek. I think it's open access, so it should be easy.
Perfect. So I'm going to stay with you. Here's another question from the audience. What are the top 3 opportunities that digital health can utilize to improve ambulatory care? In other words, where can digital health be used to improve or solve a problem that practices have?
I think you're talking about them. Access, billing, and I'm going to put prior auths in there.
Yes.
Again, not a popular topic, but a pain point for patients and clinicians alike. And if I had to pick a middle one, I mean, I think chronic care management, I'm not going to touch on. Every digital company, I think, wants to be working on chronic care management. But as Niren nicely highlighted, it's the bookends that are the pain for people. So access, billing, and I might put somewhere in the middle, one of the problems that maybe is a little bit more unique to solve that we have not solved for is preferences. Ray referenced it briefly. I want to remind everybody the definition of patient-centered care is that we are honoring the needs, values, and preferences of patients. So that means if you say never text me, that we never text you. That means if we say I only want to be called, that you call me to tell me about my bill, you don't send me a bill. And it's getting even more complicated. You're starting to see some of the EHRs capture the preference, but it's not always attached to a workflow. I'm very worried about that. And preferences are these dynamic things, right? If you have an urgent issue regarding your left eye, your preferences may go out the window, right? And you want to, convenience takes over or is more important than seeing your doctor, your eye doctor. And we really need to spend more time, I would submit to you, with digital tools capturing preferences. That's not going to be a popular answer perhaps, but in my mind, if we're ever hoping to deliver on this promise of patient-centeredness and we actually care about you and rallying around the needs of the patient, we have to come up with digital tools that can capture those preferences and then systems and workflows and processes that honor them. That to me, when we solve for that, boy, have we really broken through a massive wall in healthcare. And that is how and when people will start to feel cared for in healthcare more deliberately, consistently, with the high reliability that we're all striving for.
So I just want to talk. Sorry, go ahead, Ray.
This is one of those ones that's near and dear to my heart. We spend a lot of time thinking about this, and I suspect, Niren, you've got some thoughts too around it. But to me, the interesting thing is that I think healthcare tends to spend a lot of time looking at, if I was going to give it a clinical analogy, we spend a lot of time looking at the symptoms rather than the disease when we around these patient problems. If I think about what healthcare, if I was going to start listing the top 5 problems that healthcare struggles with right now, particularly in that ambulatory space, but even more broadly, patient access is consistently at the top of that list. Affordability is at the top of that list. This blend of how do we consumerize the healthcare experience? I think Adrian, that sense of choice and understanding patient preferences definitely falls into that category. I think it's hugely powerful. I think increasingly fragmentation is a real challenge. With these new entrant, purely digital new entrant competitors into the healthcare delivery system space, fragmentation is becoming an increasing risk and challenge. Provider burnout is one of those. I mean, those are probably among the top 5 problems that healthcare delivery systems are struggling with right now. The interesting thing to me is that if you start looking at this comes back to something I had said earlier. Every one of those is really in large part actually a symptom of an underlying issue, which comes from this supply-demand mismatch. Why don't we have better patient access? Because we don't have enough clinician capacity to be able to meet patient needs, because we've consumed all of that. Why is healthcare becoming increasingly expensive? I was hearing that primary care providers now it costs upwards of $400,000 a year to be employing a primary care provider in North Carolina. I mean, it's because of the supply-demand issue. What has given the oxygen to these new entrant competitors who are coming in and fragmenting the care delivery process? It's this lack of capacity to be able to meet patient needs. Why are providers burnt out? Because we've been turning up the treadmill and telling them that they need to be seeing twice as many patients as they used to, and not giving them the tools to make that better. And if you go one level deeper than that, the really interesting thing is it's not that we don't have enough clinicians. It's that clinicians are spending 70% of their time on things that aren't bringing real value to the patient experience or to clinical outcomes. They're spending it on administrivia. And so I'm a bit biased because this is the problem that we've been built to tackle, but I think that, to me, those are the opportunities that digital health can best bring to the forefront. It's ways to be able to liberate this incredibly valuable resource of clinician capacity that we've locked up in these non-value creating tasks that clinicians are so burdened with, and the impact that has on patient care and patient experience and affordabilities and outcomes and all the other things that come with it.
Yeah. And Arundhati, I know you want to get to the next question, so I'll be very quick. I think the only thing I would add to what Ray and Adrian said there is, I think with digital solutions, it's very important not to fall into like the grid trap where you feel like you have a feature, or you have something figured out. Like, hey, we have electronic communications. And to Adrian's point, electronic communications could mean a whole lot of things, and you have to make sure that these solutions are really well implemented. We personally experience that in billing, right, where people will say, hey, we have kind of electronic billing, but that can mean a whole lot of different things. It could just be a website, right, that is not necessarily even mobile friendly. So I think that is applicable to everything that we're talking about, that the implementation has to be really good to actually solve the problem. I think you can actually create negative digital experiences if the implementation is not good.
And Adrian, actually, I'm going to stick with you with the next question. I'm a little confused by the question. It seemed like the first part of the question is talking about concierge care, but the second part isn't. So you sort through it. The question is, I have seen some private physicians develop a personalized healthcare model where the patient pays an annual fee out of pocket for 24/7 availability via text, call, or emails. What are your thoughts on that in these times where so many people are having financial challenges and can't afford these annual costs outside of their insurance for a good doctor?
Concierge model.
Yeah. My initial reaction to that is, I think the concierge model is always going to be like a niche solution, right? Like there's going to be some small percentage of patients who do this concierge model and some small percentage of doctors who are serving them. I think for kind of if you look at it very broadly, we have to make when you have private insurance or government plan, like we have to make that work for people, because these kinds of concierge models, I don't think are actually really applicable when you get super sick, and they're not applicable to like 98% of the patient population. So that core healthcare model of you have insurance or you have Medicare, Medicaid, and then you're going into a provider like Cleveland Clinic, right? That has to be really effective, because to me, that's the brunt of the system, or that's the majority of the system. So I would say, the concierge models are very niche services, and they're not geared towards patients who are having difficulties.
Yeah.
So Adrian, I wanted to talk to you a little bit about these new ONC rules and CMS rules for interoperability that are coming into play. We recently wrote a story on that, and the idea that, important visit information, lab information has to be made immediately available to patients. And I'm hearkening back to the time when my brother was diagnosed with stage 4 kidney cancer. He died 3 years ago. And I'm just thinking to the point in time that if I had that ability to access that information then, and I got that radiological report before the doctor called me, how would I from a patient experience point of view, that would be very shocking. So I'm wondering how you're navigating that mandate with that impact on just a human being when they have a bad diagnosis.
Am I getting the softballs? Is that what's happening?
Is this a softball? I didn't you have to balance like a ballerina. You have to balance on the
Okay.
I think Adrian wanted the previous question.
regulatory side. I think that was a
So,
softball.
so I actually am so grateful you asked that question. I mean, this is something, same with cost transparency. Like, why do we need regulations to get us to do the things that we all believe in? That is not the motivation, nor should it be. Although for some, I think it does sort of push in the right direction. We've been at this problem for some time, because I want to be crystal clear. When I say access, at least in my own mind, I'm not talking about just access to appointments, right? It's access to data, it's access to your information, because how can we expect these super engaged patients running around with Fitbits when they can't access their own data? I mean, that's a whole separate conversation, but they can't be our engaged, shared decision-making partners when they're not informed. And I would also argue we're never going to have consumers when we don't have cost transparency, right? Consumers make decisions about how to use their money for value. And patients don't have that privilege. So I always take a little bit of, I got something about that word, because we haven't given them the same rights. So it's true when you ask this question about access. We've been working for many years to bring the healthcare system into more timely sharing of data with patients, which sounds like a crazy conversation to be even having, right? It's their data. And I think that's been the approach we've tried to take. On both the outpatient and inpatient side, for probably 3-4 years, we've been moving in this direction so that now we release immediately patient data. Interestingly, we spent time with both the regulation as well as our patients about how they felt about that immediate release. And I'll tell you, we're drafting a response currently that patients still have some real concerns, just as you outlined. So it's great to be the proxy, on your loved one's account. Sometimes patients forget that they have a proxy on their account. And with these new regs, it doesn't matter, it's going to get shared with that person. That's important for patients to understand. If you're not comfortable with your proxy, you need to change it, because now access is really wide open, including notes. We have been doing open notes for some time, but I want to emphasize to those on the call that what patients said was still, although I'd love to be informed about sort of non-sensitive things, for really sensitive things, I want to be having a conversation with my clinician. Even if it was even digitally enabled, so that it was Niren coming across and saying, hey, Joni, as we suspected, your PSA, well, Joni may not work, John, your PSA was really high, right? That they were even interested, if you couldn't do it in real time as a person in a timely fashion, that a video accompanied the results. And that was true of genetic testing. That was true of cancer screening. That was true of fetal ultrasounds, for example, that might tell patients gender or major deformities. And so what I'm worried about with those rules is we've made a blanket assumption that everybody wants to know everything right away. And although it's still the patient right, to refuse to open or to wait to open, it's like dangling an apple in front of someone that hasn't eaten for 3 days. The neurology of that is that someone's really going to open, they're going to want to go for the apple, even if you say, please don't open this if you don't want to know right away. So we've worked really hard with our patients to craft our messaging and to create a constructive medium to voice those concerns back to the government and say, we're all big fans of this. We're happy to do the sharing, and we just think it should be thoughtful based on what patients are saying. Because if the goal is do no harm, there's emotional harm that can accompany those results, not just physical harm at times. And hospital systems need to be more responsive, right? I mean, there's a crisscross of I want to, again, back to preferences. I want to hear from my own doctor will work until the patient reaches about day 3 of not getting their test result. And then at day 3, they're going to open that test result without their doctor. And we need to recognize that we need to be more responsive such that when that result comes in, we're right on top. And that's very hard, as you just heard, with some of what we're throwing at clinicians. Every single clinician I talk to wants to be the one to talk to the patient about the result. That's really important. We make an assumption people are too busy or don't care. That is not fair. Every clinician I talk to wants to be the one to have that conversation with the patient. So our counsel has been, have that conversation in the visit before you order the testing. Communicate to the patient that it's their choice to open the testing or not. And if they want to wait, to please wait. Please be timely in following up when those results come in. And on the patient side, you know, if these are sensitive things that we know, please have a conversation with your doc about how timely they think they'll be and what you could expect if it's this result or that result. I mean, we should be having that conversation before we order things, but I think there's some nuances here we just need to be thoughtful about for everybody's sake.
So we talked a little bit about policy, but I wanted to, given that we now know the results of the Senate from yesterday, skip ahead and talk a little, maybe ask you to be bold and predict the future a little bit. I'm going to start with Ray. Are there any policy changes you are expecting from the Biden administration that could positively affect patient experience?
Did something happen in the Senate yesterday? I must have missed that. No, I'm sorry, I'm kidding. No, I think, well, the interesting thing is, I mean, I talk with and work with policymakers at a lot of different levels. And the interesting thing is, I mean, the biggest policy shift that I think impacts healthcare is this increasing shift from a fee-for-service to a value-based care model. It is the great aligner of incentives. In a fee-for-service world, healthcare delivery systems are, and I'm being a bit simplistic about this, but I mean, in a fee-for-service world, health systems are paid for full hospital beds and full imaging suites and full cath labs and full ambulatory surgery centers. And that's not what patients want. In a value-based care world, your health systems are paid for empty hospital beds and imaging suites and cath labs and surgical centers. And the interesting thing is that that shift from fee-for-service to value-based care may get framed a little bit differently depending on which side of the aisle you sit on. But neither side of the aisle believes that fee-for-service is the future of healthcare. The question is, how do we accelerate that process? And my hope is that that's something that, despite some of the disagreements about the path to be able to get there, that the destination is so well agreed upon that folks can put aside some of those politics and help us accelerate that move forwards.
Nirain, same question to you. Anything you're looking forward to or afraid of in terms of what they might do?
I completely agree with Ray that on value-based care, I think that's going to be great for American healthcare overall. I think the other thing that we saw is, I think in one of the COVID relief packages passed recently, the supplies billing laws have changed. So getting rid of these extremely negative experiences for patients, right? So I think that law actually does a pretty good job of balancing all of the different interests and, you know, putting the patient in a much better spot than they were before that. I do think in the next few years, we're going to see more moves towards having more transparency and more coverage, right, based on how this election has turned out. And I think those will all be good things. And I think naturally providers will embrace digital technology. I don't think that's going to come from kind of a legislative angle, but I think the ROI on doing things like this will be just undeniable. I know BrightMD has a huge ROI. You know, we always aspire to deliver, you know, that 8 to 10x ROI on technology. And I think there will be other technology solutions that can do that as well. So to me, that will be kind of organic and won't come from legislation.
So Adrienne, you get the final word.
Well, if we're talking about my dreams, my dream would be, I have a dream that we are serious about equity in healthcare. I have a dream that the disparities we see in access to care, as well as the outcomes for quality, safety, and experience of care, will become more balanced, and that we recognize the role systemic racism and disparities continue to play. We didn't spend much time on that, but COVID has made that clearly an issue.
That's work.
And I'm very concerned about it, as I'm sure everyone on the call is. And my other dream in my dreamland is really thinking about including some of the things that we've talked about into the experience of the future, which is the billing experience, the empathy experience, the access experience. But empathy has to be a core component of that. We've had a lot of misses this past year around being curious about each other's perspective, and it's created a lot of divisiveness and fragmentation. And I'm hoping, I don't know if we'll get some law or regulation around empathy, but boy, what would that sound like?
From your lips to God's ears, I guess, Adrienne.
I have to imagine that would be pretty amazing. So those are my dreams.
Excellent. Well, with those sparkling dreams that hopefully will come true in 2021 and beyond, I wanted to thank each and every panelist today for a wonderful discussion, and of course to Health for organizing and inviting all of us to chat today. So thank you very much and hope to see you again.
Such a pleasure. Thank you.
Thank you.
Thank you.
Thank you to Ora and Dodi and to all of our panelists. If you would like to continue the conversation, please join us on Twitter. And now, please welcome Master Chef Matt Migliori.
What's going on, everybody? So today, what we're going to be making in this post-webinar, I'm going to be making a fresh cavatelli with you all. You all have the recipes, so I just want to give you a quick demonstration. So we're going to be making the cavatelli from scratch, right? So we basically mix all of our ingredients together. We create the dough. We need that for about maybe like 5 minutes. But I do have like a backup cavatelli dough because ideally what we want is we want it to sit for about an hour. So it can rest, it can really like kind of reach its alkaline. And then we are going to be making a Romesco Verde. Now, traditionally Romesco, it's a condiment from Spain. And they basically use like roasted piquillo peppers, tomato products, Marcona almonds, a good amount of olive oil, and it's cooked, right? So today what we're going to be doing is more almost like a pesto, right? It's going to be like a green addition to the Romesco. Okay, so first thing to get our pasta started. Okay, so I have about, I would say 2 1/4 cup of all-purpose flour with a generous pinch of kosher salt. Okay, and we're just going to dust this right into our bowl. Okay, and traditionally, like making semolina pasta with eggs and egg yolk, it's much more efficient to make it like on a counter, right? And you create like that little volcano in the middle, and then you use a fork. But with cavatelli, we are using a dairy-based cavatelli dough. Now, traditionally, for cavatelli, what you can do is use your all-purpose flour or a double O flour. Now, a double O flour is a little more higher in gluten, and that's ideal for making pasta. And we're going to be adding ricotta cheese. Now, the ricotta makes it a little more creamy and a little tiny bit acidic. Okay, so it's a really nice contrast. Okay, next thing we have our 1 cup of ricotta cheese, and I have my 1 egg mixed in here. And I've mixed this all up, right? And I've let it sit for about 20 to 30 minutes at room temperature, because when you're making pasta, you want everything to be room temperature. You don't want it to be cold. Okay, so I'm just going to go right in here, right into my bowl of flour. And then I'm just going to start by using my finger, right, just to kind of mix all this together, right? And we just really want to incorporate everything just until it starts making a dough ball, right? Now, feel free, if you have a KitchenAid at home or like a standing mixer, feel free to use a mixer, but make sure it's on low speed, okay? Because again, we just want to mix until everything's incorporated, okay? So now we're going to start using our hand until it starts forming a dough ball, right? So all the flour from the sides starts getting picked up. Okay. Going to keep kneading this. Now it's very important, right? So once we have our initial dough ball made, okay, what we're going to do is we're going to dump all this down our countertop. And it's always important to make sure that you have a very dry, very clean working surface, okay, when you're making pasta. Okay, now what we're going to do is just going to start kneading this. And what kneading is, it's basically folding the dough over and over again, right? Because what we're doing now is we're really starting to activate all that gluten. Okay, so we can just basically use this like as a sponge, right? We can just kind of corral all of our little bits of flour, ricotta cheese and egg, and we're just going to keep on pressing this and kneading this. Okay, it's definitely going to make a mess, so that's totally fine. Right, and this pasta is actually like an old school, like a Sicilian grandmother recipe. It's actually from my Sicilian grandmother, which makes it pretty nostalgic. And what she used to do after she used to make pasta, she would take all like these little bits, right? Like you see all these little bits that are like on my table. She used to collect those, dry those out, and then toast them in the oven until they turned like a little bit brown. And she used to use that as her base for her cavatelli. So it was more of like a toasted pasta, excuse me, like a toasted flour cavatelli dough. Now, if you can notice here, what's happening, right? Everything's starting to come together. It's starting to become just a little bit stretchy, right? But it still breaks. Okay, the reason why it's breaking like this is because the gluten isn't really active right now. Okay, and you can notice how it's a little bit lumpy. All right, so all we're gonna do is really just put in some elbow grease and just knead this dough. Okay, so what you want to do is you want to knead this for about, honestly, like I would say 10 to 12 minutes. It takes a while, right? You might sweat a little bit, but that's totally fine. It's totally worth it. Okay, and again, we're just activating all of this gluten so it can become way more elasticy as opposed to like, you know, how it just breaks like that. Okay, so again, we're going flat down like this. We're taking our right hand, if we're right-handed dominant, we're gonna fold this over and then push down and forward, right? And that way we create an elongated piece of dough. And then we're gonna bring it back, stretch it forward to the side, stretch it forward, back, stretch it forward, side, stretch it forward, right? So on and so forth. Right, so what you're looking for is you want a smooth ball of dough. Like I said, you can kind of see all these little imperfections and all these little lumps throughout the dough. The more you knead it, the smoother that it gets, okay? And that all comes from the gluten, right? So again, you wanna knead this for about 10 to 12 minutes, right? And then what you're gonna do is create a little ball, right? And then all you wanna do is just wrap this whole entire thing in plastic wrap or saran wrap, and leave it on your counter for an hour to chill, right? And the hour allows all that gluten to kind of relax and really do what it has to do to make the pasta unique and stretchy. So next thing, what I'm gonna do, I'm gonna get a quick little cleanup here. Okay, and I'm going to bust out my finished dough. Again, I made this dough a little bit ahead of time. It had an hour to relax and I kneaded it for about 15 minutes. Okay, and you can notice the difference on this dough, right? See how it's like really nice and smooth. It's really like elastic, right? That's when you allow the gluten to rest. Okay, so I'm gonna cut this in quarters just so it's a little more manageable to use. Okay, and then if you're doing a quarter at a time, which I recommend, I would take your other quarters here or your other pieces and keep those wrapped in plastic wrap so they stay nice and moist, okay? Just so they don't dry out. All right. So now what I'm going to do with this guy, okay, and you can kind of see the inside there, right? It almost looks like pizza dough, right? But again, it's really smooth, very elastic, okay? And all I want to do is just start rolling this. Okay, and I'm using the insides of my palms, right? Or the insides of my knuckles, right? So I can apply a little more force and a little more pressure. and I'm rolling it in an outward motion, right? And ideally what I want is I want about 1/2 inch to 1/4 of an inch diameter in my rope here. Now, if you see little like imperfections like this, right? Like how it's kind of starting to open up a little bit and it's like a little bit, you know, kind of weird, right? It's not neat, right? You're just going to focus on these little spots here, right? And this end too. And again, we're looking for about 1/2 inch to 1/4 of an inch. Now, this is a great recipe to do, right? If you're doing like 2 servings, you know, you can use maybe like half of this dough, right? And then the other half, you can just wrap that up very tightly and freeze it. Okay, and then if you want to just break it out one day, surprise a bunch of people, really style them out and show off, you break out this pasta dough and you start rolling fresh cavatelli in front of everybody. Okay. Or what you can do too, if you have like a little skinny piece like this, we can work with a section at a time. Okay, so you notice how I'm just trying to work this one out, right? Make this all nice and even. Okay, keeping my hand planted here. Just using my left hand to roll the rest of this out, so it's nice and even. Okay, if it's not a perfect rope, don't worry about it, because right now what we're gonna do is we're gonna start cutting little pillows. Similar to gnocchi. All right, so we have our strand, right? We're gonna take our knife, and I suggest that, you know, if you have a big enough cutting board, that's fine. Or if you have a countertop and you don't wanna use your knife, I suggest getting like a bench scraper or a pastry card. That way you can cut through it, right? Or if you have a countertop that you really don't care about, or if it's wood, you can use your knife, okay? So I'm making cuts that are about 1/4 to 1/2 inch. Okay, and that's when you start seeing all these little pillows, and you can see the dough starting to stretch back a little bit, okay? That's great. That's what we want. Beautiful. All right, now to form the cavatelli, I have a little plate here. I just dusted it with all-purpose flour. This is going to be like our landing pad for our cavatelli. Now, we can roll our cavatelli a couple ways, okay? So the first way I'm going to show you, if you don't have one of these amazing pasta cavatelli rollers, it's totally fine. So classically, what you would use is the back of a fork. Now, what I'm going to do is I'm going to place the cut end of the cavatelli on the back of the fork and use the whole entire surface of my thumb to roll this forward, okay? And that's what creates like the classic shape of the cavatelli, right? The reason why we have ridges and why we want ridges is because that's what picks up the sauce. Okay, so again, I'm just gonna roll this forward. You don't have to apply too much force. It's more of like a forward motion, right? Or we can use one of our cavatelli rollers and just roll these forward. And again, it doesn't have to be a complete, like a cylinder, right? You want like a little bit of a cup inside of the cavatelli there, right? Can you see those little ridges? Just like that. And this is like one of my favorite types of pasta. Like I like eating pasta that's like really, you know, has like sustenance to it. Like it's really big. It's almost like a dumpling. Okay. And again, I'm using the whole width of my thumb to just gently push these forward. And again, the dough is going to be very soft. Okay. So if it sticks a little bit, that just means that you're pressing a little too hard. Okay. Just let gravity do its thing. Okay. And again, it's all about making sure that you're set up and you're prepared. Okay. Again, like having this dish of flour ready to go, it really will, it's really going to be a lifesaver, right? Because once we dump this into our pasta water, we don't want any of this pasta to stick. Just like that. I'm just a little guy right here. Cool. And I have about, I would say maybe 2, 4, 6, 8, 10, 12. I have about like maybe 20 pieces of cavatelli here. I would say that's good for about one portion. I mean, depending on how hungry you are. again, I would say 1/4 of this dough is good for just about 2 people, okay? So what I'm gonna do, just pop everybody over here next to my boiling water. Okay, so I have my water that's boiling, and it's very important that you always wanna cook any kind of pasta, whether it's dried, fresh, if it's like a cavatelli like this or like a dumpling, you always want your water boiling, okay? Second important thing is that we want our water to be salty, as if it's like the sea, like we're jumping into the ocean, okay? So I'm gonna add a generous amount of kosher salt to my water, right? I'm gonna let that come back up to a boil, okay? Should take literally maybe like a few seconds. The reason why you want your water to be boiling, whenever you add something to something that's hot, it cools down the temperature of your pan or of your water or whatever you're cooking in. Okay, so it's always good to maintain that temperature of your water. Right. So now I'm gonna give this a little shake, make sure everything's nice and loosened up, right? And I'm gonna add everything to this, right? I'm gonna add all that flour, I'm gonna add the cavatelli, all these little bits that are on there, because what's gonna happen to the water is it's gonna absorb all that flour and all the gluten in our cavatelli, and we're gonna use some of that pasta water to thin out our Romesco Verde, okay, and to like really emulsify it. So we're gonna go in with our pasta and those little bits of flour. Let's give it one quick stir, all right? And then I'm gonna put my lid back on just so it can come up to a boil. Okay. So now just do a quick little cleanup. Okay, and your surface, and when you're making the pasta, the surface should be fairly dry, right, after you're done making it. If it starts to stick to your surface, to your counter, whatever it is, I suggest using a little bit more flour, okay? So now for our Romesco Verde, I have my peppers that have been charred and our garlic. Okay, we're gonna go right in. I have my olive oil and my avocado oil, my sliced almonds, okay, my 1/4 cup manchego cheese, my 1/4 cup parsley here, 1 cup of packed arugula, and then my 1 cup of basil. And I just want to pack all that down. And I'm just going to go right over to my blender, and then we're just going to give this a spin. Now, before we spin this, I'm going to add just a pinch of kosher salt, okay, just to get this nice and seasoned up. Now you just want to give this a quick buzz, okay? We don't want to go too long. We don't want to make it too long. All right, and that's it. Again, you saw I just took the back of a spatula just to kind of pack everything down there. Okay, now we're gonna give it a taste. All right, we still want it just a little bit chunky, right? Beautiful. Again, it's gonna taste similar to a pesto. Okay, so what we're gonna do, we're gonna turn our saute pan. Okay, I'm gonna take the lid off. I'm gonna add just a touch of this pasta water here. Okay, and then I'm gonna add my Romesco Verde. I'm just adding maybe like a cup of this if it's for one portion. Right, and we want to cook our cavatelli for about 3 minutes. Okay, and they're gonna start floating, but you want to just take them a little bit longer, okay? Okay, just about there. All right, and take my spatula. I'm just gonna mix in this pasta water to my Romesco. Now you can add some crispy pancetta to this, some guanciale, bacon, sausage, anything you want if you want to add protein. And it's really, really nice with like zucchini or peas or like any kind of green veg. All right, so once this comes up to temperature, I'm gonna take my cavatelli off here, strain this out. All right, we really want to wring this dry. Okay, we're gonna pop our cavatelli right into here. Take a look, everything's just starting to bubble nice, right? Just gonna take our spatula and mix this around and get it nice and saucy, nice and incorporated. Okay, we're gonna finish cooking our pasta in our sauce. Okay. And now we're just gonna go through a quick little plate up here. So nice and saucy, all right? Take a nice spoonful of this cavatelli in the sauce. Right to the bowl. Okay. And then just freshly grated manchego right on top. There you have it, guys. So it's our cavatelli with our Romesco Verde and grated manchego.
Thanks, Matt, and thanks everyone for joining today. I hope you have a great rest of your week.